Okay, so where do you keep your pressure wire sensor? Suppose you keep it here where the X is. You want to go as distal as possible. Ideally, the pressure wire sensor should be at least 3 vessel diameters distal to the disease that is being measured. But the more distal you go, the better it is, because then you get accumulated FFR of the whole artery. So what you're trying to measure here is this focal area of disease significant or not, and would this revascularization, focal revascularization, achieve the goals of revascularization, or would the artery still remain ischemic? Is there anything else that needs to be assessed? Is this a diffuse disease or focal stenosis? So look at this right coronary artery. I've labeled 4 areas of disease here. Starting distally, this is 1. Then you've got some degree of moderate disease here in 2. This seems to be some critical disease 3. And there is an area of disease here 4. So now we want to know, would fixing one disease solve the problem, or do we need to make a metal jacket for this patient? Which disease of these is really the most significant? So this is the FFR recorded distally by keeping the pressure wire in the PDA distal here. So this is 0.65. So FFR is significant. Now, what's the contribution of each one of them? So for that, you do a pullback gradient with ongoing adenosine. So adenosine infusion is going on, and you can see the 2 curves separating very nicely. So look at the mean values here, mean line here, the 2 lines are separated, and then at point 3, you can see there is a big step up, and then at point 4, there is another step up. So there are 2 step ups at point 3 and point 4, but the third one is the most significant one. So that means this disease is the most significant out of these 4. And how big is the step up gradient? So you have to see the lower point and the higher point and correspond them to the pressure measurements here. So this at 3, the lower point corresponds to 50, rather maybe somewhere 40, somewhere 40. So it corresponds to 40 pressures, and here the upper point over here, this corresponds to 60. So it's a 20 millimeters of mercury step up from this disease up till this point. So 20 millimeters mercury. So if we stent this disease 3 from this point to this point, that's what we've done here, and then we've repeated the FFR, and the FFR came out to be 0.81. So that means remaining disease does not require a stent at present. We can keep this patient on medical treatment. We don't need to make a metal jacket, and this spot fix is good enough for this patient. So FFR in serial stenosis, how do you do it? You measure FFR of all stenosis together from distal PD over PA. So the way we've done it, you keep the pressure wire sensor distal to all the disease. Accumulative FFR is seen. If FFR is not significant, you can leave the whole artery alone. It just needs medical treatment. But if the distal most FFR, accumulative FFR in that artery is significant, then you need to perform a pressure pullback tracing under steady state of hyperemia, which is done with IV adenosine infusion. You can't do that with intracoronary adenosine. So then what do? Then you look for the most significant step up in the whole tracing, and that is the area that you need to fix. If you want to fix a focal area, then you fix the one with the maximum gradient, and then after doing that, you again take your pressure wire sensor distal most position, and you start doing the pullback again, and then you see if there is another step up gradient or not, and what's the cumulative FFR. If the cumulative FFR is now negative, then the job is done and you don't need to do anything more. If it is still significant, then you may need to look for another big step up gradient and then fix that. Now the beauty of FFR this is that you can even see where the disease starts and where the significant disease ends by doing a pullback, and where you get the big step up gradient as seen here. You are pulling back and you get a step up gradient. You want to reconfirm this, you push it back in, and you can see again the step down coming here and the gradient coming up. So you can, by pulling and pushing the wire, the pressure sensor, you can reconfirm the position of the big step up gradient. Now look at this pressure tracing. We've compared it, and now we're going to compare it with the one that I've just shown you, where you had a big step up gradient and you had a focal point to address. Now here there is a significant gradient between the two, but if you look at the step up, it's a very gradual step up. It's a gradual step up. There is no focal big step up where you can put in a small stent. So this is representing diffuse disease. So now compare it again. This is a big step up, sudden big step up, and compared with this one where there is no big step up, it's all gradual inclination of this PD mean pressure going towards the PA mean pressure. So that's the difference between diffuse disease and the disease which has a focal step up and you can put in a focal stent. So FFR in diffuse disease, you again do the measurement of FFR, cumulative FFR at the distal most position of the whole artery. Then you do a pressure pullback tracing with IV adenosine infusion and stent only if there is a focal pressure step up of more than 10 to 15 millimeters of mercury. So what is a significant step up? It is if the step up is more than 10 to 15 millimeters of mercury. Anything less than that is considered in diffuse disease and no focal area to stent. Now, just to give you an example, this is a 40-year-old doctor with strong family history of ischemic heart disease, and he presents with atypical chest pain but positive ETT and normal echo, and this is his angiogram. So I'll let everybody concentrate on the angiogram, and I will keep changing the views. So we can see here there is some significant disease, definite critical disease in the circumflex. So you can see the same critical disease here and definitely CTO-RCA, and maybe some degree of disease you can appreciate here in the left main stem and ostial LAD. So now I've focused it for you. So you can see there is moderate disease in the distal left main, there is some degree of moderate disease in the ostial LAD, some diffuse disease in LAD here, critical circumflex, you can see again the LAD, but you don't see anything critical in LAD as such. So what do you do next? We decided that rather than just fixing the circumflex, which is an easy fix, or going for CTO-RCA, we need to first evaluate. He's a young man, we need to address the prognostic disease first, which is the distal left main stem and ostial LAD. Is that significant or not? So we tried to give him adenosine, and after 4 minutes of infusion through antecubital vein at 180 micrograms per kg per minute, there was no hyperemia, there was no effect, no pressure gradient, nothing at all. So probably he was a fast metabolizer and adenosine was not working with him. So what's the next step to do? You need to have a central venous line to give adenosine. So we took a femoral vein puncture, and from there, this is the Judkin right catheter you can see here. It is sitting in the right atrium, and through this Judkin right we gave adenosine infusion directly into the right atrium, and within 4 seconds we got the FFR readings. Anyway, so this is the IFR. IFR is 0.79. This is of course without adenosine, just with nitrates. So IFR was pretty significant. And this is the cumulative FFR of the distal left main and the whole of the LAD. Now, We did an FFR as well, and it came out to be 0.56, highly significant. And if you look at the pressure tracing, now you can well appreciate that there is a focal step up in this. Although I thought LAD might prove to be diffuse disease, but there is a significant step up, and this significant step up came right at the ostium of the left of the LAD and the distal left main stem. That's the area where we had this big focal step up. How big the step up is, you can see this comes to somewhere around 70. This corresponds to this one. The lower end of the step up and the upper end of the step up corresponds to something like 95. So it's around 25 millimeters, 25-30 millimeters step up. It's a huge, big step up. So that's the most significant point. The next thing you want to know is that your waveform was correct. There was no pitfall in that. Where is the FFR calculated? FFR is not calculated on any BPC, or so it's calculated at the right spot. This is a proper dicrotic notch and a V-shaped aortic waveform, as we've discussed earlier, and proper ventricularization of the PD waveform. So there is no pitfall in this, there is no drift. So this is accurate, and this patient has significant triple vessel coronary artery disease, and therefore we changed the whole plan, and now instead of circ and RCA dressing, this patient went for CABG, because this is where the prognostic disease is. You can't leave distal left main and ostial LAD significant disease and just fix the circumflex and come out. So that's the difference that the FFR brings in, and that's how you differentiate between diffuse disease and where you have a serial stenosis. You can see where you have a focal spot which can be stented, or within the diffuse disease if you have a focal spot which can be stented.